I'm live. Howdy, everyone. Thanks for learning about MS with me, Aaron Boster. I started this YouTube channel a few years back to try to help my own MS clinic patients learn between clinic visits. And it's my hope that through these videos and these live streams like this morning, I can help you learn too. It's super cold out in central Ohio. It's Saturday morning, not even 7 a.m. And I'm here with you to spend the next hour in an Ask Me Anything multiple sclerosis. My goal here is to connect with you guys, to receive your questions, to answer them, and to hear your comments, and to engage in what I hope is a community discussion. I've told you on live streams before that this is really fun for me. It's a great opportunity to connect with you guys. I'm also super stoked. I have a brand new Logitech webcam. I barely know how to use it. This is the first time I've turned it on. And I'm trying to make sure that the chat is active. There we go. I've got AJ's HR. Good morning. How are you? Vicky Knox says good morning. Great to see her. I've got Sonia Ahmed here. I've got a lot of people that I recognize. This is so awesome. Hello, Kathy. Hello, Samantha. My Logitech camera is really neat. It's live streaming into my computer, and I'm going to be looking back and forth to try to answer questions and look at the camera. So wish me the best of luck. I want to show you a new addition to my mug collection. This is an awesome mug. My father sent this to me, and it says, "I am your father." I have a birthday coming up, and this was a fantastic gift from my dad. So, Dad, I love you. Thank you very much. It's really cool. And of course, it's got my morning grog in it. Good morning, everyone. Sonia says, good morning. Good morning, doctor. Lovely to see you again. Francier, it's great to see you as well. I hope that you're doing well, my friend. AJHRs, it likes my mug. Thank you very, very much. Morning from the UK. Lynn, it's great to see you. I tried to time this so that folks on the other side of the pond would be able to jump on if they wanted to. Brad jumps in, watching from the Gold Coast in Australia. Currently, the temperature is approximately 80 degrees Fahrenheit. Wow. If I was able to, I'd swing my camera over so you could see literally the foot of snow that's here in central Ohio. My kids had 3 consecutive days off school. I think my wife and I were going to pull our hair out trying to entertain them here in the house. So I wanted to talk about a couple things. I wanted to answer your questions, and I'll set up some ground rules there. Many of you already know the drill. When you log on and say hello, howdy, hi, please include where you're from. I've got Landwin from Germany, which is really awesome. I love reading where you guys are coming from and where we're connecting, because really this is a growing online community. Month by month, it gets bigger and bigger, and it means the world to me. And as I've spoken to many of you before, it's my goal to help create the biggest village possible for people with MS. People impacted by MS benefit from having a large village, and there's no reason why there can't be an international online village like this one. And so I love seeing this. I've got Sarah Berry saying hello from England. It's great to see you, Sarah. Thank you for joining today. In addition, I want to remind you guys that I can't diagnose you on the internet. I can't listen to you type a couple lines in the chat bar and then deduce what's wrong with you and how to best treat you. And I want to share that with you because I hope that you can frame your questions in a general sense so that they may be applicable to everyone. But I'm not going to be able to handle the, doc, what do you think about this specific situation for me at this specific time? In order to do that, I would have to fully examine you. I'd have to look through all your MRIs, etc. I've got AJ's HR who writes, Doctor, I find that when I'm sleeping during the evening through like 8 or 9 p.m. And up all day, any others have this. And so AJ HR, maybe you're talking about problems with sleep-wake cycle. So let's talk about that for a second. It's no surprise that people with MS need sleep. Now, all humans need sleep, duh, but people with MS tend to have a smaller functional reserve. Their battery is smaller than the next guy's, and sleep is very, very important. It takes on even more importance than it might if you didn't have MS. And there are certain situations that we can run into that jack up your sleep pretty badly. For example, When people work a 9 to 5, they're forced to wake up at 6 or 7 in the morning, and they work all day long, and they're forced to go to bed at 10, 11 o'clock at night so that they can be awake during those business hours when they're working 9 to 5. Some of us, when we move away from the workforce, we lose that structure. We lose the fact that we have to be up by a certain time. And what can happen is we can start to shift our sleep cycle. And I have patients quite literally that will be up all night surfing the interwebs, kind of unable to sleep and suffering from insomnia. And then around 5 o'clock in the morning, when the spouse is waking up, they're going to bed. And this is a real problem for couples sometimes because they literally overlap and they don't have an opportunity to see one another. Sleep hygiene is really important. And I have several videos on this channel talking about the quality of sleep and the importance of that sleep, and also tips and tricks to improve your sleep. So when I edit this in the post, I'll make sure to throw a card up above looking at sleep hygiene in case you guys want to check that out. I've got Vicky Knox here from the Space Coast in Florida. Have a wonderful day. Vicky, it's great to see you. I've got Jennifer says, good morning. You look different. Netter with a new camera. Jenny from Milwaukee. Hey, Jenny, thank you for commenting on the new camera. I'm so excited. As many of you know, prior to launching my social media campaign to reach out to people with MS, I didn't involve myself with Facebook or Twitter or YouTube, and I didn't have a camera. If I wanted to take a picture of my kid or my dog, I did it on my phone. So all of this is terribly new for me. And as you can imagine, I've been watching a lot of YouTube videos on how to use the Logitech camera. So far, so good. Looking at some other questions here. General question from Detroit. Well, first of all, let me give a shout out to Detroit, the Motor City. I worked in Detroit at DMC at Wayne State University where I did my fellowship. So a lot of warm feelings coming out of the Motor City. So she writes, is it unusual to have multiple lesions on the brain and none on the spine? Excellent question. So when we say the word lesion, spot, what we're talking about is a signal on the MRI. It's a white spot on the MRI. And the medical word is lesion. Now, really what you're talking about is an area where there's been inflammation that's left some brain damage. There's been damage to the structure, to the tissue of the brain. And that white spot or that lesion is actually a pool of water, which leaves a residual mark. And in MS, you can have lesions in the holiest of holies, the supercomputer that runs the body, the brain. You can have lesions in the nerves that run the eyes, the optic nerves, and you can have lesions along the spinal cord. Now, certain people with MS tend to have a predilection to be more lesion heavy in the brain or more lesion heavy in the cord. And that's kind of an individual thing. I have some patients where their brain MRI almost looks normal, but their cord is riddled with small lesions throughout. And I have other patients, as this person from Detroit points out to us, who have lesions in the spine or in the brain, but none in the spine. Now, certain types of MS tend to have lesions in different places. And so people with primary progressive multiple sclerosis tend to have more cord lesions than people with PPMS. Likewise, they may have less brain lesions. Now, that's not true for everyone, but we can see that. Now, the question was why? And the answer is, honestly, we don't know. There's probably reasons why there's a predilection for one part of the central nervous system versus the other. But in 2019, that's information we don't have. It is important, however, to remember that MS can affect the brain and the spinal cord. And this is very relevant when it comes to surveillance MRIs. The consortium of MS centers, of which my center is a member, recommends that you have a annual screening brain MRI for people with MS on therapy. And so once a year, you're going to take a picture of their brain. But what about their spinal cord? People have spinal cord lesions. Well, the recommendation actually is to only image the spinal cord when you see new clinical disease activity that suggests spinal cord disease. Why? Because brain lesions can go unnoticed. You can have a bunch of new spots on your brain and not have any symptoms. However, spinal cord lesions, generally speaking, don't go unnoticed. Think about this. All the information from the supercomputer is funneled down into a tiny little spinal cord that's about as thick as my 2 fingers. It's really small. So if you have a lesion in that small cord, it's going to manifest some problem. Now, that's true most of the time. I'll share with you my own personal practice. I like to get an MRI of the brain every year, and I like to get an MRI of the cervical spine every couple years, even if we're not having symptoms, because it's been my experience that every once in a while a lesion can sneak through. And I want to have a good sense of what the cord looks like. And so thank you very much for that question. It was a great one. All right. So looking at a couple other questions, Marie Jose Gavin, and I apologize, I'm not very good at pronouncing names, writes in, what would you choose, Ocrevus or HSCT? So let's unpack that question. Well, Ocrevus, ocrelizumab, is an FDA-approved monoclonal antibody. It's a disease-modifying therapy. It's a medicine to combat MS. I'm a big fan of ocrelizumab. I was involved in the clinical trials that led to the FDA approval of ocrelizumab. I use a lot of it. I work with a company closely. It's a drug that I really believe in. And I have a lot of people that I've started on ocrelizumab. And I consider it to be a highly effective medicine. Now, the person asks the question, ocrelizumab or hematopoietic stem cell transplantation, so a stem cell transplant, which one? Well, in some ways, that's kind of like saying, which do you prefer, steak or motorboats? They're really very, very different. Hematopoietic stem cell transplantation is not FDA approved. You can't just go to a person that knows how to do it and then have them give you a stem cell transplant. Particularly in MS, stem cell transplantation deserves to be in the setting of research only. I do not believe that in 2019, we should be running out and getting stem cell transplants. We're learning, and we're learning at a very fast clip. There's a lot of places around the world, wonderful registries in Italy and wonderful registries studying this in Canada. There's a lot of wonderful work going on here in the United States, looking at the efficacy, safety, and tolerability of stem cell transplantation, trying to figure out who's the right patient, who's not the right patient, but it's works in progress. And so comparing stem cell transplantation to ocrelizumab isn't really apples and oranges, because ocre is a therapy that's approved by the FDA. It's a drug that you take that slows the MS. It decreases frequency of attacks. It decreases new spots on the MRI. It decreases brain shrinkage. It decreases disability. Hematopoietic stem cell transplantation is a procedure, which I'll explain in a second, and it's not yet FDA approved. We don't have all the safety, tolerability, and efficacy hashed out. Now, just very briefly, I'll explain to you what hematopoietic stem cell transplantation is like, just kind of big picture, 10,000-foot view. First, you harvest cells from the human being. You try to extract out their pluripotent stem cells, so the precursor cells that develop their immune response. And you take those out of the human body and you put them on ice. Literally, you kind of put them in the refrigerator. Then you, in my mind, murder the human being. You give them lethal doses of chemotherapy, sometimes radiation, and you literally ablate their immune response. You remove their immune response, so they don't have an immune system. Now, if you stopped right there, they would succumb to infection. But you keep them in near sterile environments, and then you give them back the pluripotent stem cells and hope that they take. And the idea is that they reconstitute a new immune system. This has been very helpful in research in dealing with highly, highly aggressive MS. I was an investigator in a clinical trial called the HALT, H-A-L-T trial, where we and our team ran 4 humans with MS through stem cell transplantation. And it's my opinion that stem cells will be a member of the MS armamentarium, but I think it's going to be about 5 to 10 years before that's really prime time. That was a most excellent question. Thank you for asking it. Now, I'm going to try to scroll back here. You guys know that I'm not awesome at trying to talk and read at the same time, so bear with me. AJHR writes, Dr. B, can you talk about black holes in layman's way as they're seen on the MRI? So he's asking about black holes, and I would love to talk about that. Again, I have videos on brain atrophy and black holes in MS, and I'll throw a card up above when I edit this in post. But let's talk about what is a black hole. When you have a naughty autoimmune system, which thinks that parts of your brain and spinal cord are foreign invaders, those immune cells, which live in the bloodstream, cross the blood-brain barrier into the brain. And then they see part of your brain, but they think they're looking at a foreign invader, and they attack it like they're attacking a virus. And they attack it using inflammation. And that inflammation can cause brain damage. Now, when you go in an MRI, you're taking a picture of the structure of the brain. And many of you that have been in an MRI are familiar with the fact that every few minutes it changes sounds. So you'll hear bing, 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 bing. It's just really annoying. And then you'll hear bang, 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 bang. And the different sounds are actually different sequences. They're different ways of capturing the image, which teach us slightly different things about the structure of the brain. So commonly when people talk about MS lesions or MS spots, they're talking about bright spots or white spots. The technical medical term is a T2 hyperintense lesion, which is a lot of words to mean a bright spot. And the bright spots on the MRI represent areas where there has been inflammation. But there's other sequences. And there's another sequence which looks at dark spots. Now, the scientific medical term for the sequence is a T1 pre-contrast, and there's no quiz, you don't need to know that. But this is a different kind of image obtained in the same MRI, and it doesn't look at water as being bright. So on these sequences, on these pictures, water is dark. And so in some of these sequences, you may see an area of brain where there's a black spot, a hole. And what that represents pathologically is actually literally a hole. If you think about the inflammation in the brain, if the inflammation is severe, it can eat away at some of the brain tissue, breaking the axons, removing the myelin, and leaving a mess. But if the inflammation is super, super intense, it can literally create a crater. It can eat away at the brain tissue. And one analogy that I oftentimes offer people is imagine a city under siege where there's a war, where there's missiles and bombs and guns and explosions. Imagine that the war was so severe that when the dust settles and the fighting ends, there's no city. There's just a barren crater where there used to be a civilization. That's what's happening with a black hole. Literally, you're looking at a hole in the brain. Now, before people get super anxious and say, oh my God, I didn't know about holes, most everyone with multiple sclerosis has black holes. And the average ratio is about 1 to 2 black holes for every 10 bright spots. And that's not gospel, that's a gestalt that I was taught in training, which has held true for the last 13 or 15 years when I'm looking at MRIs. Now, if this is news to you and you're not familiar with the black holes, I urge you to talk to your neurologist. The next time you have an MRI and the neurologist reviews it with you, which they should be doing, and they say, okay, well, here is the contrast enhanced lesions, and you either do or don't have any new ones, and here are the new bright spots, the T2 lesions, and you either do or do not have any new or enlarged ones. I then want you to say to the doctor, okay, doc, what about the black holes? What about the dark spots? Because it turns out that new dark spots or new black holes correlate with disability better than the bright spots. And so someone with an excessive number of black holes prognostically is not going to fare well. And looking at the accumulation of black holes is an important piece to the puzzle when trying to understand the MRI, looking at someone with MS. Most excellent question. Thank you for asking it. If I take a moment and reflect, there's 58 people that have joined me at 7 a.m. Eastern Standard Time. And that makes me feel awesome. Thank you for having coffee with me, guys. That's really, really cool. Jumping into the questions, I've got Fallon from Texas. Howdy do. I spent most of my summers in Dallas, Texas. Some of you know that when my family fled Russia in around 1914, about half of us went to the Midwest, and a lot of us ended up in Columbus, Ohio. And for reasons that we can't sort out, another large group of people from my family went to Dallas, Fort Worth. And so I have a lot of family in Dallas, Fort Worth. And there's a story behind why I always wear cowboy boots to work. I'll tell you that story sometime. It's great to see someone from that sunny area of the world. I've got some other questions here. What are your thoughts on the best diet? And so I get a lot of questions, Lynn, about diet. And I'll spend a few minutes and talk about it. For starters, and please hear me, there's no diet that's been proven to slow multiple sclerosis. Allow me to say that again. There is no diet that has been proven to slow multiple sclerosis. Now, the reason that I take pause to make sure that you hear me tell you that there's no diet that's been proven to slow multiple sclerosis is because you can read a lot of stuff on the internet. You can read a lot of diets that proclaim they can cure the disease, that if you simply avoid these 10 foods and only eat this stuff at this time, that it can cure your multiple sclerosis. And that makes me angry. It makes me angry because it's selling false hope to someone who is scared, and that's not okay with me. Now, look, if you go to Borders Bookstore, which is a bookstore in the Midwest, and say, "Hey, I have MS," they'll say, "Oh, good, come with us. Look at all these books that you can buy about how to fix your MS with a diet." And many of those books that are published are written by people that have advanced degrees with letters after their name, like letters after my name, MD. And to the casual reader, it looks and feels real. It's a real book. They really paid money for it. It's written by a doctor in some cases. And it's important that you know that there's been no proven diet. Now, there's a lot of diets that are very popular. A few decades back, the Swank diet was a really popular diet. And this is an anti-inflammatory plant-based diet. And there's some scientific rationale why it might be helpful. More recently, there's a person who has multiple sclerosis, supposedly, and she's a physician. And she made herself famous by writing a book where she claimed to be able to cure her MS through diet. And she has created a tremendous amount of bad, in my opinion. And the reason is because people will seek out her diet with her book that they purchased for money. And they'll say, "Well, I'm not going to take your medicines, Dr. Boster. I'm going to do what this doctor said in her magical diet." Now, the diet is a modified paleo diet. And I like modified paleo diets. I eat a modified paleo diet because I have more energy when I do that. But in the book, it says she cured her own MS. And that is a travesty. That actually makes me angry because she didn't cure her MS. She's making a claim and she's using her cultural credentials. I'm a doctor to sell a book. And that's not all right. Now, this particular diet, the Walls diet, is currently under investigation, research investigation, scientific investigation to see if it can help with fatigue. And it wouldn't surprise me if a Walls protocol diet helped with fatigue. Do I think that you should or shouldn't pay attention to what you eat? Hell yeah, you absolutely should pay attention to what you eat. And if you find that a Swank-like diet, a anti-inflammatory plant-based diet gives you more energy and helps you feel better and you keep the pounds off, I think that's amazingly wonderful. And I want you to do that. And if you follow a modified paleo diet and in doing so, your quality of life is improved and you sleep better and you have more energy, I think that's phenomenal. But I really rage against false hope and the idea that there's a magical diet out there that if you just combine these foods and avoid these foods, it'll slow your MS, because to date, we've not been able to prove that. And so forgive me if I sound a little bit intense when I say this to you. It's just something that I'm faced with on a daily basis. I have developed an opinion about what I will refer to as complementary medicine. And allow me to clarify what I mean when I say that. I'm an MD, I'm an allopath, and I was taught about lotions and potions in medical school. In therapies that fall outside of the classic med school teaching, we sometimes call complementary, which is a little bit conceited. But for the sake of our discussion, we'll use the term. And here's Aaron's 3 rules for complementary medicine. Rule number 1 is whatever you're talking about doing, it can't be dangerous. So if there's a complementary medicine or complementary therapy that could hurt you, we need to be cautious about that. An example would be a so-called immune booster. If you go to the drugstore, they can sell you an immune booster in a bottle. It's not FDA approved. It's never been evaluated by the FDA. And thank God it probably doesn't work at all. If it did work, that would be dangerous because people with MS have an exaggerated immune system. They have an overly active immune system. They don't need to do anything to rev up their immune system. On the contrary, they want to calm their immune system down. And so a theoretical immune booster would actually be dangerous. So complementary medicine, number 1, it can't be dangerous. Number 2, it can't be too expensive. And only you can identify whether something for you is too expensive or not. But if you're having to take out a mortgage or take out a second credit card so that you can pay for therapy, I'm not okay with that. Now, that's true whether it's an allopathic therapy or a complementary therapy, but I certainly don't want you to break the bank on a complementary therapy. Number 3, it can't be instead of something that I know works. So many of you know that I have this saying, I want you to be 4 for 4 in your fight against MS. Take a medicine, make sure it's working, exercise as part of your lifestyle, don't smoke cigarettes, and supplement low levels of vitamin D. So if you're doing those things and you want to add a complementary therapy, you want to add a therapy on top of what I just mentioned, not take away something, but add something, and that complementary therapy isn't dangerous and not too expensive, okay. And if you find that it helps you, tell me about it, because I think that's awesome. And that applies to diet, just the way that it applies to supplements and vitamins. Excellent question. I hope that you found the answer helpful. So Nathan writes, hello from Texas. I was diagnosed 4 years ago and healing from my first attack. My doctor would like me to switch from Copaxone to Jelenia. Any thoughts? Well, first of all, how do you do? It's nice to talk to someone from Texas. And thank you for sharing with us. This person with relapsing MS was originally started on Copaxone, and there's a discussion about changing to Jelenia. And let me share with you just my own personal opinions. Now, for starters, I can't give you specific advice, and I know that you know that, but I got to say it because I'm online here and there's lots of people listening in. I can't take that information and tell you the answer for you. This is clearly something that you have to work out with your doctor. And I know that you are, and I know that you're just asking my opinion. I want to set up some background. But I do want to make some general comments about Copaxone and some general comments about Jelenia. I have a video on this channel, which I made last year, and I think it's entitled, Is Copaxone Still Relevant in 2018? Or does Copaxone still have a role in managing MS in 2018? And Copaxone is a very mildly effective medicine. It came out in the mid-90s, and it can decrease annualized relapse rate by about 30% better than water. It can slow disability progression a little, maybe by 30%, but in some meta-analyses, it doesn't look like Copaxone slows disability all that well. Copaxone also has a mild effect on the MRI. And so this is not a gangbuster medicine. This is a very entry-level medicine from an efficacy standpoint. Copaxone is very safe. So Copaxone is a polypeptide. It's 4 amino acids in a random order, and it mimics myelin. I have some videos on how Copaxone works, and you guys can check those out if you like. But it's a safe medicine. It doesn't cross a cell membrane. It doesn't trigger a receptor, and it's not really metabolized. And so one of the upsides of Copaxone is its profound safety. There's no other drug in the MS armamentarium that's safer than Copaxone. It's a drug that we can give people when they have MS and cancer, MS and HIV, MS and really bad medical problems that require very potent medicines where there's concerns for interactions. Copaxone works excellent in that regard. It's given via shot. It's a self-administered subcutaneous injection, and you can have injection reactions. I mean, you can get skin reactions and welts and divots and things like that. Now, as many of you know, I was trained by a wonderful MSologist named Dr. Omar Khan and by another wonderful MSologist named Bob Lissack. Two great men, and I'm honored to have trained under them at Wayne State University during my fellowship. And Omar taught me to start all patients on Copaxone. Now, mind you, this was way back in 2000s when there weren't very many MS medicines out. And we were basically choosing between starting Copaxone and starting interferon. Now, Copaxone and interferon beta have the same degree of efficacy. They're equivalent in their efficacy. But Copaxone has a better side effect profile. And so back in the day, we would put patients on Copaxone. In 2019, I don't prescribe Copaxone almost ever at all. Because in 2019, we have 17 different medicines, and we have many, many medicines that are more effective than Copaxone. Now, I want to point out they're not more safe. Copaxone's safety remains amazing. It's the most safe medicine we have. But when I'm thinking about medicines with patients, my first thought, my first criteria is efficacy. I'm looking to put them on the most effective medicine they're comfortable with. Now, they might not be comfortable with most of the effective medicines, and that's okay. But I want to start talking with the most effective medicine. And as you guys are aware, I like to talk about the good, the bad, and the ugly of that highly effective medicine. And if you say yes, we'll start it. And if you say no, we'll downgrade. And we keep downgrading until I can put you on the most effective medicine you're comfortable with. And that's very, very rarely Copaxone. So let's hit pause on Copaxone and talk about Jelenia. Because the question was, how do you feel about switching from Copaxone to Jelenia? But I need to have a little morning grog. And I'm learning because I knew I'd be sitting here for an hour. So I went to the bathroom before I started, and I have a secondary container of coffee so I can get my refill. Now, Jelenia is a pill. Jelenia was actually the first pill to be FDA approved for MS. It came out in October 2010. I was involved in many of the clinical trials that led to the approval of Jelenia. I've used it for a very long time. And Jelenia is more effective than Copaxone. Jelenia is a mid-tier efficacy drug. So if I used a silly car analogy, I think of a Copaxone as like a Honda Civic, amazing car, super safe. It's not fancy. You're not going to win any races with a Honda Civic, but it's a solid car. If we use the car analogy when we're talking about Jelenia, maybe it's more like a BMW 3 Series. It's a better car. It's more effective. And Jelenia's ability to decrease relapses, in my opinion, is superior to that of Copaxone. Jelenia's ability to decrease new spots on the MRI is superior, and its ability to slow brain volume loss is superior. I'm not super impressed with Jelenia's ability to slow disability progression. It's about 30% over placebo, which is kind of maybe on par with Copaxone and interferons. But overall, I think the efficacy of Jelenia is superior to that of Copaxone. That's my personal opinion. And as I just shared with you, I'm all about efficacy. So we have to consider the efficacy of the two drugs, but we also have to consider the safety profile. Now, I have videos on my channel about Jelenia, the efficacy of the drug and the safety tolerability, and so you guys can check those out. But there's a lot more safety concerns with Jelenia than Copaxone. There's some heart concerns when you start the drug only. There's a first dose phenomenon. When you swallow the first pill, it'll drop your heart rate by about 20%, which is almost never clinically significant, but it requires monitoring. Jelenia is metabolized by the liver, and so you have to check liver enzymes to make sure they don't go up. There's a 0.4%, so very, very low risk, a 0.4% risk of swelling in the macula behind the eye, and so you have to get some special eye tests, a couple times during the first year that you're on Jelenia. And there's some mild risks of some infections and screening for some skin cancers, etc. My point here isn't to scare you away from Jelenia. It's just to point out that it has better efficacy, but it also has more concerns with safety and tolerability. So with that background, what do I think about a doctor that wants to upgrade your drug from Copaxone to Jelenia? I vote yes. I am all about efficacy, and I want you to be the most awesome version of you. And if going from a shot thrice weekly to a pill once a day increases the efficacy, I think that's a good decision to make. My only caveat is we have to make sure that Jelenia is safe and tolerable for you. And so if transitioning to Jelenia is a safe endeavor and you can tolerate Jelenia, I think you get more bang for your buck. I also want to say something about cost. Because the two drugs in the United States are about the same cost. Jelenia is more effective, but it's not more expensive than Copaxone in most insurers. And so I just want to point out that it's not as if Copaxone is low efficacy and cheap and Jelenia is high efficacy and expensive. That's not true. They cost about the same. Excellent question. Thank you very much. So jumping in here, we now have 72 people online. I'm loving that. And Jen writes in, left-sided facial burning sensation for 7 days with eye pain. Ooh, that sounds terrible. I don't see a new doctor again until April. Waiting for full diagnosis. Anything that I can do in the meantime? Well, first of all, Jennifer, I'm sorry to hear that you're going through that because that sounds god-awful. Burning in the face and pain with the eye. Now, this could be a lot of different things. She says that she's waiting to see the doctor and she's got to wait maybe a couple months. And if you can't get in to see the neurologist, but you're having facial pain, burning of your face, and pain with your eye, I think that you need to see a doctor. You need to go to the urgent care. You need to go to the ER. You need to go to your primary care doctor. You need to try to call the neurologist's office and get in sooner, but you need to be seen. There's a lot of different things that could be, and none of them are awesome. None of them are like, yay, I'm so happy I have this problem. And most all of them are treatable. And so what do you do in the interim? You got to get yourself taken care of. And I would not sit around and wait for the doctor in April. I would call my primary care doctor and say, hey, buddy, I got to get in and see you. I got a thing going on. And so that's my recommendation. And I hope that your face feels better, because that's terrible. What else do we have here? I've got, good morning. Does doing chores in the house exacerbate MS symptoms? Ha ha, that's funny. So someone asks, does doing chores exacerbate MS symptoms? And the answer is yes. Doing chores can exacerbate MS symptoms, but it doesn't always have to. So let me unpack this a little bit and explain it to you. It depends on what's going on with your MS, certain aspects of your disease, and what chores you're talking about. So if you have MS and you suffer from motor fatigue, that means that after you start to exert yourself, your body short circuits and your legs get weak, or you become profoundly tired, or your MS symptoms kick up. And many, many people I take care of have motor fatigue. And some people also have heat sensitivity, meaning when their core body temperature raises and and I'm not talking about they feel hot, I mean just their core internal temperature raises, it can short circuit their spinal cord. And so people that have heat sensitivity and motor fatigue may find that during labor, during exercise, or during certain chores, that they can have worsening of their symptoms. And I want to explain this a little bit further. I am not talking about an MS attack. I do not believe that doing household chores can trigger an attack. No. I do think that you can, if you get overheated or if you get tired, you can bring out old MS symptoms. The way that you might notice that you have more symptoms at the end of the workday as compared to the morning. I have examples to share with you of a woman that takes care of her home, and she really values herself based on how clean her home is. And let's be honest, many of us feel that way. Many of us think of our self-worth tied up into the cleanliness of our environment and our ability to host people in our home and feel good about it. And she takes her household chores very seriously. And one of the things that she does is she sweeps the floors. And she shared with me that she had a Kirby vacuum cleaner. So for those of you that are not familiar with a Kirby, these are these giant, like iron, huge vacuum cleaners. They're really high end. They're really, really good, but they're also very heavy. They're heavy to push. And she would lament how sad she was that she could only sweep or vacuum one room in her house before she was exhausted, and she would have to take a nap sometimes or rest. Her MS symptoms got worse. She had some burning, she had some numbness, but mostly she had motor fatigue. And so we had to figure out a way that she could be successful doing her chores without exacerbating symptoms. And this Kirby vacuum cleaner, not only is it amazing, not only is it heavy, it's also expensive. And so throwing it out and getting another vacuum really wasn't going to be an option. And so we used a cooling vest. She wore a cooling vest in the house while vacuuming. And guess what, guys? By wearing a cooling vest and cooling her core body temperature, she was able to vacuum her entire house. And so I'm very happy for her that through this adaptation, she was able to be successful and do her household chores. That was a great question. Thank you for asking it. I totally dread showers, Sammy writes. I am so sensitive to hot water. I have to take almost cold showers. Well, Sammy, my heart goes out to you because I get really, really cold. And I come from a place where it's cold outside, and I will sit under a hot shower. And so I empathize with you. And if I had heat sensitivity, I would want to maybe not take a shower. I might find myself being awful dirty. So how do you get around this? Well, a couple things that you might consider. How hot can it be? Can you put on a tepid shower? Can you have a tepid shower for a duration of time? Also, I always like to recommend a shower chair, Sammy. So you can buy a shower chair at Walmart. You can get a shower chair at most stores. And the reason I suggest that is if you're taking a shower and you get a little overheated, you can sit down because I don't want someone to fall in the shower. But my heart goes out to you. I will share with you, there's a medicine that's trade name is called Ampera 4-aminopyridine. It's now available in generic here in the United States, and it can also be compounded in compounding pharmacies. And it buttresses against heat sensitivity. So there's about a third to maybe upwards of half of people with MS that respond to Ampera. But Sammy, if you took Ampera and responded, you might be able to take a warm shower and not get too overheated. And so that might be something for you to talk to your MS provider about if you haven't already tried that. I don't think wearing a cooling vest in the shower would work too well. And best of luck. So here, Melanie Parker writes in, does anything other than, wait, I lost the question. Uh-oh, sorry guys, I'm not very good at this. I think she said, does any other things besides optic nerve inflammation cause problems with vision in the eye? Well, the answer is yes. So first of all, sometimes nature can be too generous. Sometimes you can have MS and you can have a separate eye problem. So we can't always just assume that the eye problem is from MS. You can have an infection in the eye, you can have a scratch of the cornea, you can have an intrinsic eye problem of the lens, you can have glaucoma, you can have cataracts, you can have problems behind the eye that are not related to MS. But common things being common, if someone with MS has eye pain or blurred vision, I'm thinking about an MS problem. I just want to point out that we always have to think outside of the disease as well to make sure we don't miss anything. And optic nerve inflammation can cause problems with vision. But I will remind you that the visual system doesn't stop with the optic nerve. The visual system is a complex series of wires that goes from the eyes all the way to the back of the brain. And damage along that pathway anywhere can cause certain types of visual problems. And so I have some patients that in their eye, they can't see stuff out here. It's like it's black. They've lost that visual field. And that's from damage on this side of the brain caused by MS. That's caused what's called a visual field cut. You can also have damage to the nerves that run the muscles that control the eye. So if my fist is the eye, the eye goes up and down, left and right, and it can intort and extort. And there's actually a bunch of muscles, 6 muscles that move the eyeball around. And those muscles are run by nerves, which are controlled by the brain. And if MS lesions affect those brain structures, you can have difficulties with eye movements. And so there's actually several different ways that you can develop eye problems from MS. And we always have to be thinking about if it was something with MS or without. So thank you for that question. I've got 78 people online. It's only 7:30 in the morning. We're sitting here having coffee and doing an Ask Me Anything multiple sclerosis. And I'm having a blast, and I want to say thank you to everyone that's jumped online. This is really a great opportunity for me to connect with you guys. It makes me feel empowered. It makes me feel energized. And I hope that you feel that way too. So let's look at another question. Cameron writes, YOLO. What's up, Cameron? You're a great guy. I hope that you and your family are doing well today. I hope that you're staying warm, my friend. I use a walking stick for extra balance. That's a really smart idea. It's snowy outside, and later today I may actually record a video on gear for people with MS in the snow. And when I say gear, I'm talking about walking sticks. I'm talking about things that you can put on the outside of your shoe that add sort of like treads so that you have better traction. I'm talking about wearing layers. There's a lot of things that we can do to prep ourselves to go in the snow. And a single prong cane in the snow is dangerous. And so I like to have a cane that's got grippers on the bottom, or 2 canes, or sometimes using trekking poles to optimize your balance in the snow. Caesar writes in and says, Dr. Boster, rituximab, ? So I'm assuming, Caesar, that you're asking about what is rituximab, or what do I think about rituximab. So let me talk a little bit about that. Rituximab is a monoclonal antibody. It's a biologic agent that targets B cells. Rituximab is remarkably similar to ocrelizumab, Ocrevus, which I talked about earlier in this live feed. Both of them are made by the same manufacturer, actually, Genentech, and they're both used in treating autoimmune conditions. Now, Ocrevus is FDA approved in relapsing MS and primary progressive MS. Rituximab is not approved in MS, but it's been around since 1993, and many of us have used it off-label to treat multiple sclerosis. And Rituxan works to treat multiple sclerosis. There was a very famous paper by Dr. Hauser called the Hermes paper, which looked at treating relapsing MS and demonstrated that Rituxan works to treat relapsing MS. A close personal friend of mine, a wonderful MS neurologist named Dr. Kathleen Hawker, ran a trial called the Olympus trial, which looked at primary progressive MS in Rituxan. And whereas the primary outcome was negative, the subgroup analysis showed that it would work in people with PPMS that were younger. I'm talking about Rituxan. So there is evidence for using Rituxan. And I'll point out that many of the clinical trial design elements for ocrelizumab that is approved were borrowed from our learnings from Rituxan. And so there are places around the United States that still use Rituxan to treat MS. And I at one time had about 100 patients with MS being treated with Rituxan. I have very, very few now. And the reason is because Ocrevus is available and it's on label. And so it's actually easier in the United States to get an on-label medicine covered by an insurer, by a third-party payer, than it is an off-label medicine. And many of the patients that we had controlled on Rituxan were able to switch over at a cost savings to the patient and the family while staying on a B-cell killer. But Rituxan is awesome stuff. It's a great treatment. I've used it for many, many years, and I like it a lot. Vicky Knox writes, same here with heat issues. My husband is super skinny and always cold. I'm always hot or sweating. Vicky, that's marital bliss, and I wish you the best of luck. It's tough. Maybe sometimes one of you could run outside. I'm just teasing. I'm not going to interfere with marital bliss, and that's a tough one to sort out, trying to see who gets to sit next to the thermostat. I have another question about Lemtrada. Pammy Sue 21 writes, Lemtrada, I'm 10 years post-treatment with 0 new flares. Have a friend whose neuro refused to treat with Lemtrada. She ended up finding another doctor to treat. Why would a neuro refuse to offer Lemtrada? I love that question. That's a great question. So thank you for asking it. And I'll start off by saying that I'm biased. I really like Lemtrada a lot. I was involved in the phase 3 trials that led to its approval. I've done research with Lemtrada. I've consulted for the company. I've done lectures for the company. I really like Lemtrada. I think it's one of the most effective medicines out there. Now, on my YouTube channel, I have lots of videos on Lemtrada. And so if you have questions about it, I would encourage you to check out the Lemtrada playlist. Lemtrada is, in my opinion, one of the most effective MS medicines. And this person points out that they took Lemtrada and they had a really great response, 10 years with no MS attacks. And they wonder why a neurologist wouldn't offer it. And I think that there are some reasons. First of all, Lemtrada is a form of chemotherapy, and many neurologists have 0 experience administering chemotherapy. They don't have the same training as an oncologist. Now, I'm a neuroimmunologist. I did 2 years of advanced fellowship work, during which time I learned a lot about chemo. I learned a lot about Cytoxan and mitoxantrone, and I learned how to administer and monitor and safely give chemo. So it was part of my formal training, but it was not part of many other neurologists' formal training. A second piece is that Lemtrada is given in a weird manner. It's given IV for 5 days, and then you wait a year, then 3 days, and then you don't give it again unless people have disease activity. And that's not normal. All the other MS drugs are given continuously. In fact, almost all other MS or all other neurology medicines are given continuously. So if there's a neurologist that doesn't have Lemtrada experience, even the way it's given is kind of unusual to them and might make them feel uncomfortable. The biggest reason I think neurologists shy away from Lemtrada is they're scared of the side effect profile. When you give someone Lemtrada, you have to monitor their endocrine system. You have to look at their thyroid function, which means you have to be smart about endocrine and thyroid. And that's not something that neurologists have to think about on a daily basis. When you give Lemtrada, you have to monitor their platelet count, and you have to understand risks if the platelet count doesn't work. There's a condition called immune thrombocytopenia that most neurologists never need to treat, and people that use Lemtrada have to know how to manage that. Also, you have to understand the kidney, because there's some mild risks of kidney dysfunction with Lemtrada. And again, most neurologists don't have to worry about the kidney. When you give Lemtrada, there's a risk of certain infections, herpetic outbreaks, and even things like listeria. And the point that I'm trying to convey is Lemtrada is a highly effective medicine, but it's a very, very complex medicine with a lot of safety and tolerability concerns. And it requires the neurologist to become at least conversant, if not expert, at thyroid medicine, in endocrine, in nephrology, and understanding kidney problems like glomerulonephritis and membranous nephropathy, and immune thrombocytopenia and infections, and things that the average neurologist doesn't think about on a regular basis. And it scares him or her, and so they just say no. Now, I obviously am biased, and I learned how to do it all, and I taught myself a lot of it, and I feel very confident. We've used LMTa in over 250 patients where I work at Ohio Health, and I think that we do a really bang-up job of it. But that doesn't mean that every neurologist is going to take the time or the energy or the desire to teach themselves about it. And so here's my opinion. If a neurologist isn't comfortable using that therapy, I don't want to try to talk them into it. I don't want to make her or him do something they're not comfortable with. I don't think that's in the best interest of the patient. However, that same neurologist has to recognize they have a limitation, and they have to be willing to refer their patient to a center that will give LMTa. Now, we actually have a destination center. We will bring people in. They fly in from different places to receive LMTa, and then they go home. And we monitor their REMS, labs, and stuff from afar. So I'll give an example of a wonderful family that I'm honored to take care of, and they live in Colorado. And she flew out and got 5 days of LMTa and went home. And she flew back and got 3 days of LMTa a year later and went home. And we see each other about once or twice a year in clinic, and we do a lot of work online, and we manage her at a distance. Why? She wasn't able to receive LMTa. Her doctor refused. And so she came to our center to receive that. Now, I'm not saying all this because I want people listening in to go to their doctor and demand to be sent to a center for LMTa. No. I'm simply sharing why a given neurologist might not feel comfortable. When we finish our training at, age 30, 32 or something like that, we've learned a lot of stuff, but sometimes we think we know everything we're going to know, which is nonsense. And when I think back to the standard of care and the cutting edge when I finished my training to now, it's completely different. And it forces me to constantly learn, which I actually enjoy doing. I've had to learn a lot about hematology, endocrinology, nephrology, dermatology, OB-GYN, because of the side effect profiles of my medicine. But that's part of my mission, is to make you the most awesome version of you possible, despite having MS. And if that means that I need to adopt a new therapy and learn new things, I personally want to do that. And if I'm not comfortable or I need help, I reach for it. And I'll make this last point. You don't have to be a neurologist and an endocrine expert to give LMTa. You need to be a neurologist who has a friend that is an endocrine expert. And so here at Ohio Health, we use a team. We have endocrinologists that are awesome, and they understand LMTa. And so if my patient has an endocrine problem, I know how to identify it, and then I refer to the endocrinologist, and together we manage it. I do the same thing with the nephrologist, the same thing with the hematologist, the same thing with a dermatologist. I have a village, and I extend that village with experts that I can then share with my patients. And so when there is a will, there is a way. And if we need to talk about LMTa, we can find a way to do that. That was a great question. Thank you very, very much. I loved it. Moving right along. And I know that I'm not reaching everyone's question. It's my intention, if I have enough time, to go back through the feed. And if you didn't get your question answered, I'll try to answer it in what I'm referring to as the live stream after party. I'll publish a video where I try to answer as many of the questions I didn't get to as possible after this is over. But let's take a couple others. Vicky Knox writes, I've been having a lot of muscle spasms at night mostly. Is it so bad? It's so bad it wakes my husband up as well. Do you have a preference for meds that help? Well, spasticity stinks, and spasticity is very, very common in MS. So let's talk a little bit about it. So if you look at my arm and I want to bring my hand to my face, two things have to happen. This massive bicep of mine has to contract, and this gigantic tricep back here has to relax because they're opposing muscles. And so I don't say bicep contract, tricep relax. I just say coffee to my face. And my brain and spinal cord orchestrate the contraction of one and the relaxation of the other opposing muscle. When there's been damage to the brain and spinal cord, that can get jacked up, that can get messed up. And so you might want to do this, but your tricep didn't get the message and it's still trying to do that. And you're trying to do this and you're trying to do that. And the result is a tug of war of your own muscles. And that can cause spasticity, which manifests in three ways: spasms, which is like a shaking limb, a cramp like a Charlie horse, or a limb that it's hard to bend. Now, people with MS are at increased risk of spasticity, and upwards of 70% of people with MS have some degree of spasticity. Spasticity is made worse under certain circumstances. Number one, when it's cold outside. So welcome to the Midwest. Welcome to sunny Columbus, Ohio. The sun's coming up, and as I look outside, all I see is snow. And it's cold outside. And spasticity is always worse in the cold temperatures. It doesn't matter how hot you keep your home. You can't heat up your home enough to combat the winter in Ohio, and it's going to be cold out, and that's going to make spasticity worse. Number two, spasticity is worse when you're not moving, when you're still. So the fact this person tells me that their spasticity is worse at night makes perfect sense. Because at night, you're not walking around. You're typically sitting watching television before you decompress, or you're having dinner, sitting down, and then you're in bed and you're laying down flat and you're not moving. And so waking up in February in Columbus is rough for spasticity. And there's a lot of things that you can do to treat spasticity. I have several videos on my channel about spasticity, so I'll throw a card up above with a playlist on a bunch of videos on spasticity. But let's just go over a couple things. Number one, stretching is the bomb. Stretching is awesome. And stretching out your muscles has super valuable results that last for several hours. Stretching doesn't help you tomorrow, it helps you today. And so what I would recommend that people do is before you enter into the bed, you've already come into the bedroom, you got your night clothes on, you've already gone to the bathroom. Before you climb into the bed, I want you to stretch out. Now you have to hold each pose for at least 30 seconds. Otherwise your muscles don't learn what you're trying to pull off. And I would stretch out your calves, I would stretch out your quadriceps, I would stretch out your hamstrings, your hips, your buttocks, I would stretch out your lower back, and spend 5-10 minutes stretching out before you get in bed. What you'll find is you have a lot less spasms and cramps at night. I also, by the way, recommend stretching when you wake up in the morning. Same thing. Before you exit your bedroom, spend another 5 minutes stretching. Now, if you can stretch before you go to bed and when you wake up, I want you to add in one set of stretches in the middle of your workday. And what you'll find is without adding a medicine, you can really help your spasticity become minimized by doing that. Staying warm is challenging, but the warmer you are, the better. And learning that staying still is a problem, it gives you a tool. Get up and move around. Now, not when you go to bed because you need to be sleeping, but many people find that as they sit at their office and they type and they're sitting there for 8 hours, they get stiff as hell. And so I want you to look at the clock, and you may find that you need to get up and walk around the office and stretch out your legs and sit back down so that you avoid having spasms. The same thing is true when you're driving. I have a lot of patients that will travel a couple hours to come see us. And it's not uncommon that people will come from Cincinnati, Ohio to Columbus, Ohio. And that's a 2-hour car trip. And for a lot of my patients, being in a car for 2 solid hours without a break is a recipe for disaster. When they get out of the car, they can barely bend their legs. They're spasming, they're cramping, they're hurting. And so there's a city halfway between Columbus and Cincinnati, a little place called Washington Courthouse. And I recommend that people driving from Cincinnati stop at Washington Courthouse and they walk around and they stretch, get back in their car before they take off again. By breaking up the trip and by moving and stretching, they can markedly impact the success they have in dealing with spasticity. Now, the question specifically asked about drugs, and there's a lot of drugs to treat spasticity. My favorite drug is baclofen. I like to use baclofen 3 to 4 times during the course of the day. Baclofen can cause sedation and confusion and dizziness. It's like a distant cousin of beer. And so we have to be very cautious about how we apply baclofen. And we have to raise the level of baclofen very slowly over many weeks to get the person used to it. At night, I'll use baclofen, and sometimes I'll add another medication. I like Xanaflex or tizanidine. Tizanidine is very, very sedating, and so we really only use that at night. Those are my two favorite oral antispasmodics. And for the person who asked the question, I would most certainly check with your own neurologist about what's right for you. But no matter what medicine you use, take advantage of the stretching and the walking around. These can be really, really valuable and very helpful. Most excellent question. Thank you. So let's look at a couple other questions that we have here. Here's a question from Rotten One X's. Dr. B, I have some issues with bladder at night when I lie down in bed. I seem to have issues with the sensation and knowing when I need to pee. Any words of wisdom? Yes. So bladder is a very, very common complaint. Most people with MS at one time or another are going to have a bladder issue. And bladder issues are very, very common. The most common bladder problems are either A, a tight little spastic neurogenic bladder that can only hold half a cup of coffee before it's full. And then you have to sprint to the bathroom. And people have symptoms of urgency, meaning I got to pee right this second. And if you don't move, I'm going to pee anyways. In frequency, constantly getting up to go to the bathroom. And nocturia, which means I'm getting up multiple times a night to go to the bathroom. And accidents where they can't hold the bladder and they're trying to get their pants down and then they wet themselves. There's another kind of bladder problem with a big floppy bladder, but the bladder neck is locked shut and they can't get the urine out. And so they have bladder retention. And these people will have a sense of fullness, but they'll go to pee and almost nothing comes out, or they'll sit down and think they finished peeing and stand up and then have to sit down again, or they can have some leakage because they have a giant bladder full of urine and it's really, really high pressure and it starts to leak out. And then there are people that actually have both problems. And so bladder is a very common thing. Now, this person says that they're having issues at night. And so let's talk about a couple tips. Now, I, of course, have several videos on my channel about bladder. So I'll throw a card up above when I edit this in the post, and I'll include links in case you want to check those out. But we'll spend a few minutes and talk about some tips and tricks today. Tip number one, water is good for you. The more water you drink, the better. And most people say, whoa, whoa, doc, I need to avoid water. I drink and then I have to pee. Well, if you don't drink water, if you don't hydrate, you're going to have very, very concentrated urine in your bladder. And concentrated urine is an irritant. It will irritate the bladder wall and cause bladder spasms. You don't want that. Also, if you have bacteria in your bladder, you want to flush them out. You want to dilute the bacteria. And so if you're not drinking much, you're doing the opposite. You have a little tiny bit of urine with a lot of bacteria in it, which is a setup for a urinary tract infection. If you drink more water, good things happen because you dilute the urine. So it's less acidic and there's less bacteria. And it also is clearing them out. So you're constantly clearing out your bladder. So although it sounds paradoxical, drinking water can be very helpful, but we have to be thoughtful about when we drink water. I want you to drink 2/3 of all the water you're going to drink in the first half of the day. So you have to be thoughtful. Now, many of us don't really start to really hydrate until they get home from work. And that's exactly the opposite. I need you to do more water drinking in the first half of the day and not the second half of the day. Why? Because I don't want you making urine when you go to bed. If you drink most of your water up front, and I'll tell you about how to do that in a second, and then you basically stop drinking most of your fluids after the dinner hour, you're going to go into the bed making less urine. Keep in mind that after you have a glass of water, you're going to be processing that water and making urine for about 6 hours. So if you have your last drink around 6 p.m., you can expect to be making urine through till midnight. But if you have your last drink of water at 11 p.m., right before you get in bed, man, you're definitely going to be waking up to pee, midnight, 1, 2, 3 a.m., and it's going to interrupt your sleep. So how do you get all that water in, and how do you get it in the first half of your day? Well, here's a recommendation. If you want to try this out, it needs to not be a punishment. You can't feel like, oh my God, Dr. Boster's making me drink so much water. So let's make it easy. First off, drink 1 glass of water with each meal. So when you have breakfast, have a glass of water. When you have lunch, glass of water. Dinner, glass of water. That's not asking too much. Then I would ask you to drink a glass of water between each meal. So you could drink a glass of water before breakfast. That's like extra credit. But definitely have a glass of water between breakfast and lunch in the middle. And also have a glass of water between lunch and dinner. If you drink those 5 glasses of water, breakfast, in between lunch, in between dinner, you're doing a really good job of water drinking. And many red blood Americans don't drink any water at all. So that would be a huge advantage. And you notice that we're getting it all in before it's evening time. Now, if you're like me and you love yourself some coffee, there's caffeine in coffee and that's dehydrating. And so if you're trying to keep track, for every cup of coffee, add a glass of water. Otherwise, you're going to get dehydrated. And for those of you that are enjoying a brewski or a beer, same thing. You might want to drink 1 glass of water for every beer so that you can kind of remain fluid hydrated. Otherwise, if you're only drinking beer or only drinking coffee, you're going to find yourself dehydrated. And so that's something that you can do to help with bladder. Obviously, you're going to empty your bladder before you go to bed at night, and that can help. There are a lot of medicines that help with bladder. And there are these medicines, you've probably seen the commercials, gotta go right now. These pills that you can take that allow that first bladder problem I talked about, where there's a tight little racquetball bladder, to open and relax so that you have a normal size bladder. And this can cut down on frequent trips to the bathroom at night. So there's a bunch more tips and tricks that we could talk about, but I'll encourage you to check out that link that I put to the channel videos so that you can look at those and learn more. Thank you for the question. So it is about 7:54. We've got a few minutes left before the top of the hour, and we're going to wrap some things up. There are 88 people online. That warms my heart. Looking through here, Sonia writes in, I can't sit for long before my legs and ankles swell. They have done heart tests, and my heart is great. What's the cause? That's a great question. So I find that a lot of people with MS can develop swelling of their ankles. And if you notice, it tends to be worse on the leg that moves less. So many people with MS will tell me, I have a good leg and a bad leg. My left leg's good, my right leg's bad. And what they mean by that typically is the bad leg doesn't move as easily. And so maybe these people are walking unassisted or with a assist device, but their bad leg doesn't move as often. And when we're sitting in clinic, I pay attention to how often you move your legs. And you may find the bad leg doesn't wiggle. It doesn't move around very much. And if your legs aren't moving very much, there's a problem. Because the way that the circulation is set up, the heart pumps the blood down and gravity pulls it down into your feet. And then when you pump your foot, your calf muscle contracts and it squeezes the blood back up. The veins have one-way valves. So as you walk and as you pump your calves, you're literally pumping the blood back up to your heart. But if you're not walking or you're not pumping your legs, or your bad leg's not pumping as much, the blood is going to pool and it's going to collect and it's going to swell and it's going to be uncomfortable. So what do we do? Well, if you can walk, then you want to walk more, right? And that's not a very nice thing for me to say, because if you have trouble walking, you can't, and you would love to, but that's not going to be an option. So what else can you do? So there are several things you can do. Step number 1, when you repose at night, when you're chilling out on the couch, put your feet above the level of your heart. Now, a lazy boy recliner with your head here and your legs here, that doesn't cut it. You need to have your feet above the level of your heart. And so you might choose to spend a couple hours laying on the couch with your feet propped up on couch pillows, because that gives your body an opportunity for the blood and the fluid to drain out of your legs back up into your heart. And that can make a big difference. Here's a pro tip. Take 2 red bricks and put them at the base of your bed, at the foot of your bed, not tall, just the 2 inches. So you raise your bed up by 2 inches. Now, when you're laying in bed, you're not going to feel like you're falling backwards because it's a very, very slight incline, but your feet will be slightly above the level of your heart. The point here is, as you sleep at night, you're going to drain and you're going to wake up and your legs are going to be way better than when you went to bed. Now, another tip is to purchase something called Job stockings, J-O-B stockings, or TED, T-E-D hose. TED hose or Job stockings. These can be picked up at the supermarket or at the pharmacy, and they look like white stockings, but they're not stockings. They're really, really tight stockings, and they're tighter in the feet, and they get looser as they go up. And what these do when you wear them is they help push the blood up. For any of you that have spent time in a hospital, I want you to check out the nurses' ankles. And the reason is because you're going to notice that most of the nurses walking around the hospital have white stockings on. And those are not some dress code. They're wearing Job stockings or Ted hose because they're on their feet for 12 hours. And if they didn't wear those stockings, their feet would start to swell. And so you can purchase the same thing and put them on in the morning, and that's going to help a lot. And if you find that during the course of the day you have some time off, kick your feet up, but make sure it's above the level of your heart. All right, that takes us to almost 8 o'clock, and I'm going to wrap up this Q&A, this Ask Me Anything live event. I am so terribly thankful that you guys were willing to jump online Saturday morning and spend a few moments having coffee with me and talking about multiple sclerosis. Once again, my name's Boster, and thank you for learning about MS with me. I appreciate you guys participating. I love the comments and I love the interaction. And as long as you guys continue to enjoy doing this, I look forward to doing it again. I've got my new Logitech webcam. I'm super excited about it. And I hope to join you here on another live Ask Me Anything with Dr. Boster, maybe in 2 or 4 weeks, but we'll definitely do it within the next month. Until my next video, take care.